Welcome to this side event on behavioural and cultural insights, focusing today on health literacy. Your hosts, the countries of Austria, Portugal and the Russian Federation and the WHO Regional Office have been looking forward to welcoming you to this session. We hope you will find it interesting, fun, engaging and motivating. But before we start, let's take a minute to think about health and why behavioural and cultural insights are so important. How many times have you heard someone say that going for a run is good for you? Or that you should eat a balanced diet? Or disconnect from your devices to help you reduce your stress? Or that you should make sure to attend vaccination or cancer screenings? Do you follow all of this good advice? Perhaps you do, but the fact is that many of us are not applying the healthy behaviours we could in our daily lives and in the way we use health services. The reasons are many, and there is no one-size-fits-all approach to health and well-being. What might work for some people may not work for others, and things often crop up interfering with our ability to look after our well-being. Sometimes our own health just feels like a closed book. For us, Behavioural and Cultural Insights, BCI, is all about understanding the barriers and drivers that people experience in adopting healthy behaviours and making good use of health services. And, importantly, to use this insight to shape health policy and services so that they are possible, acceptable, convenient and attractive. Everywhere in the region, countries have set ambitious goals to improve the health and well-being of all. These goals cannot be reached without an understanding of the barriers and drivers to health that people experience. We're looking forward to a discussion with you about how we can best do this together. Today's session is just the starting point.
Good morning, good afternoon, and possibly even good evening to all of you joining us in the room as guests on Zoom and online via the stream. My name is Niels Fietje. I'm a technical officer in the Behavioral and Cultural Insights Unit, and I will be facilitating this side event on health literacy in the context of behavioral and cultural insights. But before we begin, I just wanted to mention a couple of important housekeeping announcements. Now, I know many of you have been part of these meetings for the last few days, so you know how Zoom works, but I just want to remind you that we are going to have simultaneous translation throughout this event. And if you're on the Zoom platform, you can avail yourself of a translation feature by simply clicking on the globe icon at the bottom of your interface and selecting the language that you'd like to hear this conversation in and that you'd like to follow along with. Now, with that out of the way, allow me to say a little bit about today's session. The side event will introduce the EPW flagship initiative on behavioral and cultural insights, and within that context, we're going to be showcasing some examples of initiatives that are related to health literacy. But the event will also explore the status of health literacy among the general population in the European region, and hopefully we're going to be able to shed some light on the challenges in these areas and in areas where action is required, as well as on the measures that have been taken by member states and the way forward. Now, it's my pleasure to introduce my colleague, Katrin Harbison. Katrin is the Regional Advisor on Behavioral and Cultural Insights, and she's been leading the development of the BCI unit since the creation of the flagship initiative, and she'll now say a few words by way of welcome and introduction. Over to you, Katrin.
Thank you very much. Excellencies, honorable ministers, delegates, friends, good day and good afternoon. A warm welcome to this Regional Committee side event on behavioral and cultural insights, today focusing on health literacy. From us at the regional office, but also from our co-hosting countries of Austria, Portugal, and the Russian Federation. Last year, in the framework of the European Programme of Work, the member states of the European region decided to prioritize behavioral and cultural insights as a flagship now being implemented under the leadership of our director, Dr. Nino Bazzoli. Integrating behavioral and cultural insights methods into health policy and planning really isn't straightforward. And I want to say that this field and the promises of this field really are still underexplored and underutilized for health. Nevertheless, we have been impressed to see the achievements and the progress made in countries during the pandemic. And I want to note, including in countries across the region that do not have a long tradition of applying such methods in their health policies. Health authorities in every country have shown a genuine eagerness to understand their populations and to adjust their pandemic response accordingly. And this is really just the beginning. In the coming years, we will work together to leverage the value of engaging with and listening to our populations and identify and address challenges that they face in making healthy decisions in their daily lives as well as in their uptake of health services. All of this to help achieve the health goals that we have set jointly in our region. So once again, a warm welcome to you all.
Thank you very much, Katrin, for those introductory remarks. Now, before we continue, I wanted to take a moment to introduce you to an interactive tool called Slido that we will be using throughout this meeting. You can access Slido in a browser window on your computer, or if you want to avoid shifting between your browser and Zoom windows, it may be easier to access Slido via your phone or another mobile device. And I'm going to explain briefly how to use it and how to interact with it. So for those of you who are in on the Zoom platform, you'll see in the chat a direct link to Slido and then some instructions. And in that case, really all you have to do is click on the link and it will open a new browser window. You'll be placed directly into the right page, and hopefully you'll be able to interact with us both in the polls and for the questions. Now, if you want to use Slido on a separate device, or if you are joining us via the stream, then I'd ask you to take whatever device you want to be using, open a browser window, and type in www.slido.com. You'll then see a page like the one that you see on the screen, and into the box you will be asked to insert EuroBCI as the event code. So that's hashtag EuroBCI. And that will allow you to get through to the page for interacting either with questions or with polls. Now, just to explain, throughout the session, we will be asking a few poll questions, and this is going to be accessible to anybody watching this event, whether they're on Zoom or they're in the stream. And we're also encouraging you to use the discussion platform, the Q&A platform, to ask questions to our panel members, because we are not going to have time after each of the panel members do their interventions to stop for questions. So we will be gathering all those questions up at the end and putting them into the discussion session. If you do have any technical issues, for those of you who are on the Zoom platform, please do let us know in the chat, and we'll endeavor to help you with those. So, with that being said, I'm now going to hand back to Katrin, and Katrin is going to give us a bit of an overview and present the vision of the newly created Behavioral and Cultural Insight flagship initiative, as well as the role which we see countries playing as we move forward. Katrin.
Thank you. There you go. All right. So to introduce the Behavioral and Cultural Insights flagship, let me start by introducing Sarah. Sarah represents a religious community. And a few years back, I was involved in a project with a research study and various types of engagement with her community to try and understand why Sarah's children and other children in the community were vaccinated to a lower extent than people outside of their community. There are many potential reasons. Maybe she just didn't get round to it. Maybe there was actually resistance in the community, or maybe it was about trust, or maybe it's about something else. What we realized through this process was that all of these factors, to various degrees, played a role. The assumptions before we started was very much that it was about trust and community resistance. What we saw was, while all the factors did to some degree play a role, we were interested to see the degree to which convenience played a role, meaning factors that didn't have anything to do with Sarah's perceptions or her knowledge, but rather how services were provided to her in a way that fit her life. Because Sarah and her peers had many children in their households, so they had to take the bus to the health facility. The waiting time was long. The waiting rooms were not child-friendly, no toys to play with, no paste for the buggy, and even just booking an appointment was actually a bit of a hassle for Sarah and her peers. So with this insight, a range of new initiatives were initiated. Also some very simple things like a child-friendly facility with toys, something I think could be done in many, many places, or a pop-up reminder on the physician's computer screen. So if Sarah came by for something else, they would make sure to remind her, it's actually time for your child's vaccination. And the outcome, vaccination coverage did actually increase, well, at least until COVID hit and other challenges arose. So why am I telling you this story about Sarah? I'm telling you this story because it's really such a nice illustration that understanding the factors behind people's behaviors is a really good investment. If we go with our assumptions, we may invest in interventions that have very little impact. It's like everything else with health. If we know what's wrong, we can agree on the treatment. And with this, we're applying a truly people-centered approach. And this is really what we want to do with this new flagship that Nils just asked me to introduce. Together, as a region, over the years, we will build more experience in understanding the barriers and drivers that people are facing, like it was done for Sarah and her peers. And also, we will have strengthened capacity and expertise to use these insights to strengthen health services, health promotion, health policies. And of course, we hope for increased prioritization and also increased coordination across all of the stakeholders who are involved in this field. And with all of that, our ambition is that we will have fostered new scientific evidence in this underexplored area. Evidence, for instance, as regards what are the most effective intervention in supporting people in taking up healthy lifestyles in their daily lives. For example, that's as regards tobacco or alcohol or physical exercise or nutrition. Or another example, greater insight into the factors that affect some of the very complex health areas, for instance, those that relate to people who are experiencing disadvantage, and how we can translate insights like that into multifactorial action in these areas. And this may be in areas that relate to the uptake of preventive health services, or screenings, or the use of appropriate use of antibiotics or other treatment. Today, within this context, we're focusing on health literacy. We see health literacy as one factor among many others that affect our health. But in fact, it's a really good example of a barrier as well as a potential driver to health. And during these turbulent times of the pandemic, the importance of health literacy really has been reiterated. We've looked at behavioral insights data from surveys that have been conducted in countries across the region with our support. And we can see from this data that people who are older, have chronic illness, have poorer well-being, poorer mental health, are also more likely to have lower health literacy, meaning they find it difficult to find or understand or use information about COVID-19 or COVID vaccination. Is that important? Yes, it is important, because we can also see from this data that people with low health literacy are also less likely to follow recommended behaviors, restrictions, and less likely to have trust in health workers. But as I said, health literacy is one factor among many others. Or actually, when we look at this data from the COVID, we can see It's one factor that is intertwined with many other factors that affect our health. And I guess that's where I will end this short introduction to our behavioral and cultural insights flagship by saying that this is a really complex field. Challenges are many, and we will seldom have one solution that fits all. But really understanding why people behave the way they do and how they can be supported to find the opportunity, the capability, and the motivation to lead healthy lives will allow us to help reach the ambitious health goals that we have set for our region. In our team, we're really looking forward to exploring this fascinating field together with you, so today and in the years ahead. Thank you.
Thank you very much, Katrin, for this excellent overview and also for articulating your vision of the flagship and how we see its importance. Now, I want to briefly take the temperature of the virtual space in which we're in to see what people think about behavioral and cultural insights with a quick poll question. So here's a quick reminder for those of you who would like to participate, and I encourage you all to participate, to go to www.slido.com and enter the event code EuroBCI into the field. Or if you want, you can click on the link that's been provided in the Zoom chat. If I could ask our colleagues to switch to the Slido page to display that on the screen. And if I could ask our colleagues to start the first poll question. There we are. So you'll see the question there, and I'm just going to read it to you, but feel free to answer it in your own time and when you see it. So the question that we want to ask you is, do you think, this is really about you, your personal opinion, do you think that there were times during COVID-19 when more behavioral and cultural insights might have improved the pandemic response in your country? Now, the options here are never. I hope not many of you are going to say that. A few times, many times, or indeed all the time. And we can see that the poll is moving. We'll give it a couple more seconds. But it's good to see that the temperature in the room is amenable to our discussions, that most of you do think that there were at least many times, or at least indeed a few times for these kinds of behavioral and cultural insights interventions to have an important impact on the COVID response. And we certainly share that opinion as well. So thank you very much for participating in this poll. We'll be doing a few more throughout this session. And I'd now like to move us into the next part of our event today, where we will be hearing from our co-hosts. So as we do this, we're going to begin drilling into health literacy with the help of our co-hosting member states, Austria, Portugal, and the Russian Federation. So thank you indeed to those colleagues who are supporting and collaborating with us on this session. So through the lens of health literacy, our co-hosts will collectively illustrate 3 important steps in the BCI journey. The gathering of localized, nuanced, and culturally contextualized insights, the translating of these insights into action, and finally, making sure that these actions are indeed impactful and people-centered. So to start us off on this journey is our first speaker, Maria Lopatina. Maria is a researcher in the Russian Medical Research Center for Therapy and Preventive Medicine under the Ministry of Health of the Russian Federation, and she's also a research representative in the WHO European Action Network on measuring population and organizational health literacy. Maria will share an example of how even asking the right question in health literacy survey can be a delicate and culturally sensitive process. So thank you again, Maria, for joining us. Over to you.
Thank you very much. Я буду говорить по-русски, поэтому прошу переключить перевод, включить перевод. И, уважаемые коллеги, я рада приветствовать вас на данном мероприятии, и я очень благодарна за возможность выступить от лица целой группы международных экспертов в вопросника по изучению грамотности в вопросах здоровья. И прошу запустить презентацию, если это возможно. Я не вижу презентацию, к сожалению. Коллеги.
Thank you, Maria. Just to let you know, we're working on it, and I think we'll have them up in the next couple of seconds.
Okay,
So
thank you.
feel free to go ahead, or you might want to wait for. Oh, there we are. I think they're coming up now. Thank you.
Итак, в 2009 году Рут Паркер представила простую схему, где, с одной стороны, личные навыки и способности людей, и, с другой стороны, требования и сложности системы формируют и влияют на грамотность в вопросах здоровья. И это актуально и по сей день, когда требования растут, системы усложняются, а улучшаются ли при этом навыки и компетенции населения, учитываются ли интересы всех групп населения при этом. И на следующем слайде мы можем увидеть, что мигранты – одна из самых уязвимых групп населения в этом отношении. Could you please switch to the next slide, please? Yes. Итак, на фото, сделанном в 1991 году, русские мигранты высаживаются в аэропорту Израиля, и, как мы видим, их лица полны страха и надежд одновременно. Переезд в другую страну, как правило, связан с языковыми и культурными барьерами, что зачастую ведет к препятствиям в интеграции в обществе и в результате может вызвать серьезные затруднения и ограничения для здоровья, а также стигматизацию в новой стране. Среди растущего числа иммигрантов в мире, на следующем слайде, next slide, please, 25 миллионов людей из бывшего Советского Союза, кто обычно говорит на русском языке, имеют общее историческое прошлое и общую или схожую систему здравоохранения. И многие из них живут в Германии, в Израиле, в США. Целью данного исследования стала адаптация вопросника, next slide, please, вопросника, разработанного в рамках сети действий ВОЗ для изучения грамотности в вопросах здоровья среди русскоговорящего населения в Германии, в Израиле и в США. Переводы с английского на русский язык были выполнены профессиональными переводчиками в каждой стране-участнице. Была проведена экспертная оценка, и вопросник был протестирован в фокус-группе. И мы хотели бы провести просто несколько примеров языковой и культурной адаптации в результате нашей работы. И next slide, please. Например, в вопросе, насколько вам легко или сложно решить, какое повседневное поведение влияет на ваше здоровье, слово «поведение» оказалось не всем понятно в контексте здоровья. Более привычны для респондентов были такие слова, как «привычки» или «образ жизни». И наш этот вопрос был адаптирован соответствующим образом. Вопрос, насколько вам легко или сложно понимать инструкцию во вкладыше к лекарству, был непонятно, имеется ли в виду понимание в связи с размером букв, или это касается понимания содержания инструкции. В этой связи инструкции для интервьюеров. И еще один пример культурной адаптации. Вопрос, имеется ли у вас такой член семьи или друг, который вы могли бы взять на прием к врачу? Этот вопрос вызвал недоумение, поскольку для нас нетипично брать на прием с собой друга или члена семьи, поскольку целью вопроса было изучение социальной адаптации и социальной поддержки, то он был адаптирован соответствующим образом. И в заключение хотелось бы сказать, что данное исследование, next slide, please, данное исследование может служить примером совместной международной и межкультурной работы в качестве важного шага перед исследованием. При этом важно выделять ресурсы и время для этого важного шага перед исследованием для тестирования и адаптации вопросника. Подход, основанный на поведенческих и культурных факторах, касается не только мигрантов, но и различных групп населения. И, наконец, исследования должны быть адаптированы к культурному контексту изучаемого населения. Я благодарю вас за внимание, уважаемые коллеги. Thank you very much for your attention.
Thank you very much indeed for these insights, Maria. They show us exactly, I think they show us exactly how critical, but also how difficult it can be to ask the right questions in the right way. But they show how, in doing so, we can really also create better surveys that allow us to have more impactful findings. Now, I'm sure many of you will have questions for Maria. As I mentioned before, we can't take them now, but please do use the Slido interface to ask your questions, to write them down. There's also an opportunity there to vote or like the questions that you think are particularly important. So do have a look over there to see whether or not you might want to ask a question for Maria or any of the speakers that are going to come. Now, meanwhile, it's my pleasure to introduce our next speaker, Christina Dietscher. Christina is head of department of non-communicable diseases, mental health, and geriatric medicine at the Austrian Ministry of Social Affairs, Health, Care, and Consumer Protection. But she is also the chair of the Austrian Health Literacy Alliance and policy co-chair of the WHO European Action Network on Measuring Population and Organizational Health Literacy. Christina will share some thoughts on how to translate findings into action using the European Health Literacy Survey as an example. Christina, thank you very much for being here with us today. It's over to you. Thank you.
Thank you so much for the introduction. It's an honor to participate in today's session on behalf of Austria and the AMPOL network and to share with you some thoughts on how to translate findings around health literacy into action. Next slide, please. Next, please. Can you hear me?
Yes, we can hear you.
Yes. Okay, can you switch to the next slide, please? Because it didn't seem
I think we're working on it.
Okay, thank you. Well, I just try to continue anyway. Well, why is it important in the first place to measure and take action on health literacy? I think we've heard already in Katrin Harbison's introduction that it really matters for personal health and healthcare decisions, but it also matters for healthcare utilization and healthcare costs. So the topic of health literacy really is important for individuals and healthcare systems alike. And if we want to select the right areas for intervention, data can be very helpful for us to determine where to intervene and to support evidence-informed intervention and practice. Data can show us which areas in the public health and healthcare system are in most need of improvement. They can help us to select the topics that we should focus on. And last but not least, data can help us to select the target groups that need special attendance in relation to their health literacy. And because of the importance of health literacy, WHO Europe launched a resolution on health literacy at an earlier regional committee meeting with a strong focus also on health equity. Next slide, please. Thank you. So because of the importance of health literacy, Austria had the honor to co-found the AMPOL network on measuring population and organizational health literacy, together with more than 20 countries from the whole European region in 2018. And the MPOL network is unique insofar as it brings together policy and research from the participating countries so as to support this translation of findings into action. And we were also able to perform the health literacy survey, HLS19, despite the corona pandemic, with a total of 17 countries. Some representatives of these countries are here as co-hosts of this session and also in the room. And we are currently preparing the launch of the international study report, which will take place on the 8th of November. And we are also discussing steps towards the next survey wave that we hope to be able to conduct in 2024 with all of you, if possible. Next slide, please. So what can countries that participate in a survey like HLS19 expect as outcomes? Well, first of all, we see that health literacy is not a minority topic. It really concerns large parts of the populations in the participating countries. Up to 75% in those countries that participated in MPOL have problems with limited health literacy. And as Katrin Harbison already mentioned in her introduction, there are some groups of populations that have a higher risk of limited health literacy. This concerns especially the financially deprived, those with a low social status and level of education. And concerning specific topics, HLS19 for the first time collected data on some specific areas where health literacy is important. We know from this data that navigating the healthcare system is difficult for up to 59% of the surveyed populations. This means that huge parts of the population really have problems to find the right place for their health problem, where they can receive help for their problem. Also, digital health literacy, that means dealing with digital health information, is difficult for up to 58% of populations. And vaccination health literacy, which is an important area, not least in relation to corona, is an important topic for up to 44%. Communication with medical doctors, at least for up to 26% of populations, seems also difficult. Next slide, please. So what follows from these findings? What can we do about these things? Well, of course, MPOL and HLS19 want to develop recommendations for evidence-informed policy and practice. And there is a very general recommendation, which is that interventions should be selected on the basis of evidence, feasibility, and relevance for target groups. Of course, ideally based on national data, because you saw on the last slide, there is a huge range of outcomes between the countries, and it's really important to know where you stand so as to select those areas where intervention makes most sense in your country. Then we heard from Katrin in her introduction that behavioral and cultural insights is very much about making service use and information use convenient for people. So this is very much also in synergy with what health literacy wants to achieve. It's about bringing information and communication to the people and empowering them to make best use of health information and communication. And for best effects in this relation, it seems important to address the systems level, the organizational level, and the individual level, and to have systematic and integrated interventions on all these areas. In Austria, for example, we invested in capacity building around health literacy. We have a governance and a financing structure. We train the workforce. We look at legal regulations and how they need to be adapted to support health literacy, etc. On organizational level, we encourage healthcare and other organizations, also schools and extracurricular youth organizations, for example, to adopt an organizational health literacy friendly approach. So we want them to have something like a health literacy universal precautions approach understanding health literacy as a quality criterion of organizations by bringing information and communication to the people in these organizations. And of course, on individual level, we need training activities and, for example, to support people to distinguish between good quality and fake information, which is crucial when it comes to fighting the infodemic around Corona. And there are many more examples than I could mention today from Austria and from Poland, HLS 19 member countries. So there is really a good case for intervening in health literacy, and luckily good examples on what to do about that. Now that already brings me to the end of my presentation. Next slide, please. And I would like to thank you very much for your attention, closing with the quote attributed to Peter Drucker, what gets measured gets done. And I think that's very true for health literacy too. Thank you.
Thank you very much indeed, Christina. I think your examples of the health literacy survey really demonstrate very well the importance of evidence-based policymaking and also the implementation at country level. I mean, collecting qualitative and quantitative data and information is key to informing context-specific actions. I think we can all agree. Once again, I see that there's already beginning to be some activity on Slido. Please do go over to www.slido.com and put in the event code EuroBCI if you want to interact with those questions, or if you want to pose your own question. We'll be coming to them at the end of our session in order to foster the discussion. But before we do, I do want to introduce our last panel member for today, who is Miguel Telo de Arriaga. Miguel is head of the Division of Literacy, Health and Wellbeing in the Portuguese Director General of Health, and he's the co-chair of the WHO European Action Network on Health Literacy for Prevention and Control of NCDs. Now, I believe in today's presentation, Miguel will talk about an example of an intervention that's been implemented in Portugal during COVID-19 to improve health literacy about the pandemic. And Miguel and his team is ensuring that this implementation is also impactful. Miguel, if you're ready, I'd like to hand over to you.
Thank you very much, Niels, Your Excellencies, your dear colleagues. It is our great pleasure to be here with you sharing this side event on the Regional Committee. It's a very good opportunity to share not only our experience, but also to combine, and my job is quite easier today because this is like summing up all the two presentations that were already promoted by the colleagues from the Russian Federation and from Austria. So it's like a kind of putting it into place and into practice all the things that the colleagues already mentioned. So it is my great pleasure to show you our Portuguese experience in facing those these kind of approaches. So next slide, please. Okay, so in Portugal, as well as in the other countries, we were tackling mostly non-communicable diseases with health literacy. So we focused most of our health literacy approaches through NCDs, but suddenly we needed to do something else and something different, a different kind and a different type of action. So the usual measures that we knew that worked, we have to resync it and we have to focus it again to a different challenge, which was COVID-19. But we knew that our first vaccine was the behavioral one. So we knew that to tackle COVID-19, we needed to do something about health literacy and about behaviors on our population. So we started something that we call social mobilization and community engagement through a process of proximity and people-centered. And so that's why we developed a new kind of figure that we call public health agents and micro-influencers. And those were the ones that we tried to develop, to teach, and to put into practice and into field, so they can be the ones that could share the correct information and that could be close to each one of our parts of our community. So that's what we have done. Next slide, please. The process was quite simple. We identified a number of entities, for example, civil protection, fire departments, municipalities, of course, health professionals, and we trained them with 2 different trainings about what was COVID-19, what was SARS-CoV-2, how was which kind of measures should we take, which kind of public health measures were we taking, and why. And then we also provide them how to communicate with the population that were around them. We also developed a toolkit that everyone could use and to share within their communities. And so that was our strategy, to put into practice and to promote somehow the knowledge, the health literacy on COVID-19, and try to help people to reach everyone in their communities. So we use people from different jobs and from different places, and we try to get into their jobs this kind of new information. We had the version 2.0 on this training, which was related with vaccines, and we provide them all the information related how the vaccines were developed, why are vaccines important, and how to communicate with the population and with their communities the importance of vaccination. So we provide with these micro-influencers that we called public health agents this kind of information so they can reach everyone in the population. So next slide, please. We had multiple and different partners, and we trained more than 5,000 people around the country. It was really, really a big challenge because we needed to not only to collect the people that wanted to be involved in this project, but also to create information systems so we could collect and we could measure somehow the kind of approaches that they were having in their different communities. And this was really, really a big challenge, but at the same time, it was, at least we felt that it was really important for us and really important for the communities. Because imagine in every part of the country, we had someone that had the correct information, the correct sources, and that could reach their neighbors, their communities, their organizations, schools, and to provide the correct information. And at the same time, we also had like it concerning and to put into practice the same message at the same time, because we felt during the pandemics at the beginning, it was, I would say, easier to communicate because not everyone knew and had lots of information related with the virus and with the disease. But then after some time, we started to have different kind of experts from different fields talking in the media, talking everywhere. And then suddenly we started to have multiple approaches and multiple ideas from the same situation. So to tackle also that issue, and Christina Ditcher already mentioned it, we needed to combat not only fake news, but also to combine and to provide them the correct and most recent evidence to the population. So we made a kind of approach, we made a connection with these micro-influencers. So we provide them the information and they gave us some feedback related with what were the main questions and the main issues that the population was facing during that period of time. So we provide them the correct information, the correct sources, and they could spread them all over the country. And that was really, really useful for us. And we believe that was also useful for the colleagues that were on the field. I would like to share with you only an example with of the National Republican Guard that we also had as one of our stakeholders with one of our partners on micro-influencers. We train these militaries from all over the country and we provide them all the information. They create their own system to provide and to collect information related with this approach. And we now have that information. We are still working together on what to share and what to see. And there were something that we call almost like the sentinella doctors that we have that could somehow reach us and try to get us the correct information in what was people feeling on the field, what were the main needs. Combining with that, we also developed a strategy that we call health literacy intelligence, and we are measuring the risk perception of the population since the beginning of January 2020. So since we had the first cases in Portugal, or before that, and combining with that information and with our micro-influencers, we customize the needed information and the communication approaches that we have. So one size fits all, it's not suitable here. So we try to combine this information, and we also try to provide these micro-influencers the possibility to share this information with all of the cultural issues that we have in the different parts of the countries. So the way to speak, the expressions, even the possibilities that they have on their communities, how to reach people and how to get it. So this was for us one of the most important issues. So to combine all of these items and to provide the correct information to the population. Next slide, please. So as a conclusion, and I will just sum up my presentation, we think that this has this kind of approach on the micro-influencers has an enormous potential for the growing power of social mobilization, not only for health promotion, but for health protection and also for disease prevention. It is absolutely amazing the amount of people that we had and that we needed, but also that we had and that wanted to be on board with us to share with their own communities the correct health information. It was really, really impressive for us. It allowed us to tackle groups, specific groups of the population that usually we didn't have the possibility to reach. We had the possibility now to customize our cultural and behavior approaches so we could have a more efficient response and a more efficient way to reach our community. So this is the example that we would like to share with you. Of course, we will be available for any question that we have. We are now working with WHO to evaluate this project. And we hope that with this evaluation, we can improve even more the micro-influencers approach. And we hope to get it not only for transmissible disease, but of course also maybe to adapt it to non-communicable disease and try to reach the population in the most effective way as we can. Next slide, just to thank you and to tell you that we'll be, of course, available to any question that you have. Thank you very much for your time.
Thank you so much, Miguel. I think really a fantastic project, and one that is not only creative, but also is showing some really useful insights at the population level with regard to health literacy and COVID-19. And hopefully also a process that can be used beyond just the epidemic. Again, a reminder, the questions on Slido are beginning to heat up. It's wonderful to see your interaction. Please do go to slido.com and enter the event code EuroBCI if you want to participate on the Slido discussion. We have one final intervention, a video intervention that we'd like to show you at this point. It's an example of a country implementation in practice and how information is shared with migrants to help them navigate their way through the intricacies of the state healthcare system in Sweden. Now, our colleagues from Sweden are here today with us, and we'd like to thank you very much for sharing this inspirational story with us. If I could ask colleagues to please roll the video. Thank you.
Det känns så varmt i hjärtat att berätta för dem. Att de får information. Den som jag inte... Mitt namn är Nuria Halimi. Och jag kommer från Afghanistan och har barn, barnbarn. Och jag bor i Karlstad. Så jag kom till Sverige för 23 år sedan på grund av kriget. Mitt jobb är att jag skulle ge information till kvinnor som kommer från Iran och Afghanistan och pratar dari och persiska. Och vill jag ge dem information om deras kropp. Och vad har de rättigheter och vad har de, kan de göra med sitt kropp och inte gör. Och jag har olika filmer om olika ämnen så berättar jag för dem. När man kommer från annat land det är jättesvårt att lära sig språket fort. Och det här informationen som RFSU har på sina filmer, det är jättebra att de lär sig när de kommer, inte första veckorna eller första månaden, men så fort som möjligt för att det här informationen det ger dem jättemycket kunskap om deras liv och deras kropp och deras rättigheter. För att det är stor skillnad. Om vi ger exempel med graviditet, att en kvinna blir gravid här i Sverige, barnen och blivande mamma blir kontrollerad varje månad eller 2 gånger i månaden, eller det beror på behovet. Men de känner sig trygga och självklart när de känner sig trygga, barnen är trygga i magen. Den här tryggheten ger dem trygghet för hela vårdsystemet här. Jag är så glad att jag ger och hjälpte så mycket kvinnor att de kom och få informationen. För mig behövs inte att veta 1000 personer, det räcker för kanske en person berättar för den andra och tredje och fjärde. Och de har redan gjort och de förstår lite. Så det är mycket. Det kom en mamma till mig och en flicka som var 11-12 år gammal. De var väldigt oroliga, särskilt flickan som var jätteorolig. Och vad händer om jag får mens? Och så frågade jag hennes mamma, går det bra om jag visar det här RFSU-filmen om mens? Det går bra. Så jag gick på en hörn med henne och så visade jag filmen till henne och så såg hon. Och så, men det är inte så farligt, det är inte så farligt. Nej, det är inte farligt, det är normalt. Varje flicka får mens. Men det betyder att du är frisk, du växer, det är bra att du får mens. Och hon var väldigt rolig och bra. Och sen berättade hon för sin mamma. Jag har tittat på filmen handlade om det här, så nu är jag inte rädd längre. Det var ju bra.
Thank you very much. And thank you again to Sweden for helping us produce this film. So we're entering into the discussion section now, where we really want to hear your opinions, your thoughts on everything that's been said, or perhaps on things that haven't been said. So please do use Slido to enter your questions, and we'll try our best to answer them as we proceed. But before we go and start answering questions on Slido, I do want to take a moment now and introduce someone who I hope is going to kick us off and hopefully inspire some more thinking about health literacy. So I'd like to invite Taylor Mali now to the front, and Taylor is going to present an excerpt from his poem "An Apple a Day is Not Enough," which, even though it never really mentions health literacy explicitly, it's nevertheless a powerful ode on exactly that topic. Now, Taylor is one of the most well-known poets to have emerged from the poetry slam movement in the USA. He's a vocal advocate of teachers, and he's performed and lectured for teachers all over the world, and his YouTube videos have been viewed by millions of viewers. Taylor, thank you so much for being with us at what I think is 5 o'clock in the morning for you in New York, and it's over to you. Thank you.
Thank you so much. It is an honor to be speaking to the WHO. I don't believe I've ever been translated into so many languages simultaneously. I love the fact that you have invited a poet to bless your meeting with a poem. They say that poets and artists are the raw nerve ends of society, that they alone cannot save humanity, but without them, there would be little worth saving. Here is, as Neil said, an excerpt of a longer poem called "An Apple a Day is Not Enough." I have been invited to stay for the entire meeting, and I may lurk for a few minutes, but please forgive me, Your Excellencies, if I go back to bed. An apple a day is not enough. I will read this slowly for all of the translators, but just know that in English, there are lots of rhymes in this poem. Good health is a skill, and teachers need to teach it. And now you've got me preaching, so I might as well preach it. Health is not a one-semester class you take in middle school. It should be the part of every subject, not the exception, but the rule. Learn about health in math, in English, and in social studies. Work on a project about nutrition, in science with your buddies, and parents need to be involved too. Teachers can't do this alone. Good health starts at home. We need to own this issue because the stakes are high. What does it matter if we try to increase our scores in math and reading if scores are dying before their time because they got fatter and fatter? Healthy students make wealthy earners, not to mention better learners. The choices you make every day have the biggest impact in the biggest of ways. Check it. Why else would they say an apple a day keeps the doctor away? But new solutions to old problems, that's capitalism's favorite way to play. Who cares about keeping the water clean and pure? Is there really a problem if they can't sell you the cure? Don't keep looking for new technology to be your medical savior. Of course, it's easier to be saved by a miracle than it is to change your behavior. So we need to value health education the way we value math and reading. We can't keep feeding our children the same old lessons like junk food full of saturated fat and sugar and chemicals. We can do better than that. We can and we will. And that's the truth, because the future belongs to the healthy youth. Amen. Merci. Dankeschön. Spasiba. Dziękuję. And tak.
Thank you very much indeed, Taylor, for this inspiring rallying cry, I think, and for a reminder to us that health literacy is in what you would call, in the WHO lingo, a whole of society responsibility. We've now got a bit more time to see if we can get a discussion going. So if you're in the virtual room and you'd like to contribute, so if you're on the Zoom platform, then please use the raise the hand function, and we will call on you, and we'll encourage you to unmute your microphone and have your video camera on and be a participant in the room. If you're on the stream, we still encourage you to participate via the Slido questions. So please do continue to ask your questions there. We've got a number coming through, and we'll be trying to go through them. But before we do this, I know that I want to give the floor to the Russian Federation, who've indicated to us previously that they would like to... They're not ready? Okay. In that case, why don't we start out with any questions in the room and see if there are any hands up. I'll pause a moment to see if we get any hands up. But otherwise, I'm going to ask our colleagues to please share the Slido screen. And we can have a look at some of the top questions that are coming through here. And I can see that one of the most popular questions, rising to the very top, is for you, Miguel. I think you've really captured the attention of a lot of our audience. And so maybe I can ask you to say a little bit more about how the micro-influencers in your project were selected. Can you say a bit more about the criteria? And whether or not this is quite specific, a declaration of independence was needed, or anything along those lines. Over to you, Miguel.
Okay. sorry, I was trying to connect my micro, but it wasn't possible. So thank you so much for your questions. They were for us a big challenge to select the micro-influencers. But we, as you all know, as we all know, we are facing tremendous times to tackle this pandemic. So we tried to get one of the easiest ways to get to the micro-influencers, fulfilling the requirements that we thought that were the minimal requirements needed to have them on board. And those were to get them into official places, where people were already working, where they already had to maintain and to have lots of specific backgrounds and so on and so forward. So we choose people that were already working, for example, on social services, on civil protection, the militaries, and so on. So that way we were having some of the ethical issues already on board, because people were having this micro-influencer approach on their own jobs. So they needed to fulfill the things that they daily were doing. Of course, taking into account their responsibilities and their way to approach people and to reserve all the ethical requirements were already on board. So that's why we have chose them in these specific places. It was the easiest and probably the fastest way to get these micro-influencers on board, assuring the ethical procedures.
Thank you very much for this insight. And perhaps it's also worth saying, for anybody who is interested in hearing more about this intervention that we can perhaps explore during this session, please do get in touch with us, and we're happy to connect you with Miguel. We're beginning to get a few people in the room raising their hand, but before I take a question from the virtual room, I do want to address one question here in particular from Mark Backer to Christina Dicha. It's the second question here on the screen, and it's asking, Christina, it's to you to say, to what extent do you think the pandemic may have impacted the survey outcomes, and whether or not there's a percentage comparable to whether the percentages are comparable to the original health literacy study? Christina, do you think you'd like to answer that question? I think you are on mute, Christina.
Okay. Can you hear me now?
Perfectly.
Yes. Okay. Thank you. Well, of course, the pandemic impacted on the way we could perform the survey. For example, some countries wanted to do it by face-to-face interviews, but then switched to telephone or online surveys because of the pandemic, because it was not possible to do face-to-face. Also, the times of data collection varied between the countries. So we have, the countries collected their data at different times during the pandemic, so we cannot give an overall answer on the basis of the data that we have here. But concerning the range of populations affected by limited health literacy, I think that was to be expected also as compared to other surveys around health literacy. So actually the proportions of people affected by limited health literacy are not a surprise, and I think there's not that much impact actually from the corona pandemic.
That's very interesting and good to know. Thank you very much for that, Christina. Again, I do want to encourage participants in the room to also raise their hands if you'd like to, and if you'd like to take the floor. We very much encourage you to, and we want to hear your thoughts and opinions. I want to ask one more question that I think has been coming up the ladder here, so to speak. And maybe, Katrin, I can ask this of you, actually. This is from Dr. Tim Chadbourne in the UK, who I think in another post says he's very supportive of behavioral and cultural insights and is ready to support the effort. But he poses this question. Some say behavioral insights is effective to reduce health inequalities by using techniques that do not need health literacy. Does the evidence support this? This is kind of a bit of a question about health literacy by stealth. Katrin, do you have any thoughts on that?
And I also have to unmute myself. It's a learning we all need to have during this pandemic. Anyway, yeah, I certainly do have some reflections on that. And thank you, Tim, for that question. I'm wondering if you're also, I mean, the bigger context of your question is that when we talk about health literacy, whether we risk placing the responsibility for health solely on the individual or on the communities, that they're responsible through their health literacy to for ensuring their own health. And it is a risk if we talk about health literacy that we talk about people rather than the systems and the health services that need to serve them. But I think the examples from both Portugal and Sweden really show that it's not about placing responsibility on individuals, but it's really about using systems and services to support them in making good decisions for themselves. However, to respond to your specific question, yes, there is certainly evidence that sometimes changing even smaller things in the environment can have an impact on health. And with the example before from Sarah and her religious community, we heard that a simple thing like a pop-up reminder on the screen of the physician when Sarah and her peers came by for something else, a pop-up reminder to say, oh, by the way, it's time for your child's vaccination, is something that can make a difference. We know specifically for vaccination that the evidence is clear that if there are good recall and reminder systems in place that use the right type of approach and messages to people, that can actually increase vaccination coverage. So those are examples of changing small things in the environment, thereby reaching health targets. But I do want to add to that I don't think anybody thinks that a pop-up reminder on the screen or a call and reminder system, which are really important, but that they alone can address the issues that relate to now specifically vaccination, but also other health areas. Often these issues are very complex and require multifactorial action. And in terms of Sarah and her peers, maybe we also need to train health workers. We need to ensure child-friendly facilities, as we said, and we need to work with the community. We need to work with influencers in the community, maybe with Sarah and her peers themselves. So often it's the combination of the small things in the environment with other more complex interventions that actually take us to where we want to go.
Thank you very much for that, Katrin. I think we have a couple of hands in the room. So at this point, perhaps I can ask Bente Mikkelsen to unmute herself and to say a few words. Thank you, Bente.
Thank you very much, and I just want to enthusiastically congratulate the Euro region for really taking the leadership on this. And it's such a pleasure to see Austria, the Russian Federation, Portugal, Sweden, and all of your smiling faces. You know, this is serious business. What we have seen during the pandemic is that we are not able to actually reach out in the context where people live and breathe. So even in situations where we have access to vaccines, we are not necessarily able to have the uptake. So I think we have seen the serious business. And I just want to sort of complement the picture that has been discussed today, just to give you a couple of ideas from the global level of WHO as well. So as you know, we have been working on NCD and health literacy for a while. And again, thank you actually to the same countries and to Euro, because there has been a working group ongoing for several years, and you have been spearheading this as well. And we have now several national health literacy projects. So of course, I don't want to take time. I just want to share my enthusiasm, and I'm waiting impatiently for all the results coming up, and I look forward to work together And I think we need to do this in a much better way because we need to build fairer society. We need to involve the people living with the conditions, the diseases, to encourage co-creation and really, as was mentioned early on, to understand their context to make our tools work. So thanks a lot, and thanks for having me, inviting me to this very, very nice session. Thank you, Hans.
Thank you indeed, Bente. It's very good to see you, and we look forward to continuing our collaboration very much as well. There's a couple more questions here on Slido that I would like to go to. One is actually addressed to Miguel again, but I think it's actually a broader question, and it's one about building trust. How do you build trust in patients? How do you change their mindset, the mindsets of doctors who will act as who still act very paternalistically towards hesitant patients? How do you create an environment for both for health literacy, but also beyond health literacy, where patients are willing to engage with healthy behaviors? So it's a question that I'd like to start off asking you, Miguel, because it's addressed to you, but maybe I could ask the whole panel to reflect on that. So first, let's start with you, Miguel.
Thank you so much again for this question. I think it's an excellent question. It's like a trigger point. To build trust, we need to do several things. The first one is to tackle and to manage and to evaluate where people feel more trust with. We know, for example, that in Portugal, people do trust the information resources like the digital spaces, but they trust the most on their health professionals, nurses, pharmaceuticals, and medical doctors. And so that's where they ask the more information, and that's okay. But it's quite important for us to know and try to reach those kind of people and to tell them where to look for information and to provide the correct information. And we don't need to be afraid to share the things that we know. But at the same time, and we are talking here about behaviors, we need not only to provide information, but to activate people to use that same information. And that's for us one of the most important items that we are working on, and that we are working with, of course, the health professionals to try to activate these kind of behaviors based on the information that people have and on the information that people collect. So we had a different challenge here when we talk about COVID-19, which was to communicate the uncertainty, to communicate that the things that we knew today probably will change tomorrow, or probably tomorrow we'll have different information. So this was really, really a tremendous challenge. And when we talk about behaviors, to communicate this uncertainty and to communicate this risk perception to the population was something, it was probably one of the most important items that we had. And as I told you, we were not only working on this behavior, but also working on risk perception, so we could customize the information for the population. But it's a huge challenge to provide this trust on people. So we have to keep and to persist on our way of doing it, and especially to be very smart, and allow me the expression, to communicate the uncertainty. So I think that was the thing that people were complaining the most, was something that we said yesterday was probably different 2 days forward. So that's really, really a big challenge, but we need to keep stable in the things that we are saying and to activate people.
Thank you very much, Miguel. I think this will have to be the final question, in fact. And so I wonder, Maria, if you could briefly reflect on this question as well, with regards to trust and building trust in relation to, let's say, health literacy survey participants.
Yes, thank you, Nils.
We can hear you.
Oh, okay, sorry. Yes, we totally support Miguel's suggestions, and I think it's very important to build the trust within the community. So in order to create such atmosphere and find opinion leaders who would lead people and find the correct words and correct information for focus groups of population. And also we see how much trust people give to medical specialists, medical doctors, and we need to use this trust in order to build trustful relationship. So information we provide should be very easy to understand, very clear and trustworthy in order to continue this relationship, especially in times of challenge, in times of crisis. So actually, I guess that is it what I was willing to say.
Thank you very much.
And actually,
please go ahead.
Oksana is ready to join.
Okay, thank you very much.
Is that Professor Oksana Drapkina?
I'm here. Is it okay?
We have a little bit of feedback on the line. If there's somebody in your room, they might have to mute their microphone. There we go. That sounds perfect.
Thank you very much. Thank you very much for the kind invitation and for the possibility to have a talk today. Do you hear me?
Very well.
Thank you very much. We are very proud for our survey and for this experience, for this trial, because we share all this information, and this is the basis for the some decision how to improve the situation. It is very important, and dear colleagues, thank you very much for this great experience. And I would like to say some words to present the part of this experience of the Russian Federation of participating of this international population health literacy research. And in general, health literacy level is sufficient in the studied population sample. This is the 61%. This is sufficient percent, but the main attention we should act to the 39%. This is percent population whose health literacy level is limited. It is important to draw attention that the aim of the study is not to group the population by health literacy level, but to identify target population where our target communication skills and our target program should be useful. And for sure, we do it for improving, assess, understanding, evaluation, and applying health information. We identified groups of population age 65 and more, having a low level of education, low social status, and financial deprivation. And the results have also emphasized the importance of developing digital and media health literacy skills of the population, skills of critical assessment and application of information, and taking into account the growing demands for the digital skills, especially for this age group, more above than 65. And abilities of the population of this age group especially. And the study demonstrated the need to increase public trust to information and to establish effective communications in a people-centered healthcare system. And we share this information with our Ministry of Health. what say in the end. And in the end, I would like to thank for sure the International Collaboration Center for methodological support and for organization support for our, I think, every week or every month for our meetings, and wish good luck with further studies. We are ready for it. Thank you very much.
Thank you so much for those important points, Professor Drapkina. I see we have one further hand up from Austria, Dr. Verena Gregoric-Schega. Perhaps I could go over to you for your thoughts.
So thank you, Chair.
We can hear you very well. Oh, I think I spoke too early. Perhaps you're on mute again?
So, do you hear me?
Now we do, yes.
So, thank you. I would like to express that Austria highly appreciates and welcomes the regional office support of health literacy, and especially taking it today as an example for BCI in practice. You have already heard from Christina Teacher from the network on measuring health literacy, which was co-founded by Austria under the umbrella of the regional office, together with 20 countries, more than 20 countries of the European region. And we are grateful for the ongoing support of this topic and for the fact that more and more countries from the region engage in improving and measuring health literacy. Measuring health literacy is particularly important to use its potential to addressing and achieving SDG 3. We believe that international networking can provide valuable support to move forward nationally as well as in the region. Therefore, Austria calls upon all member states that have not already done so to join this valuable network. Thank you very much.
Thank you so much, Dr. Gregoric-Schega, for your thoughts, and we agree with you entirely. We're reaching the end of our session today, so I'm going to leave it at that. I am going to say thank you to all of you for participation and hand over to my colleague Katrin for the last bit of this session. Katrin, back to you.
Thank you very much, Niels. Before we close the session, I just wanted to say a few words about a process ahead of us, because today marks the first day of a really exciting process that I'm looking forward to. Next year, at the next regional committee, we will be presenting a regional framework for behavioral and cultural insights, a framework that we have not developed just ourselves, but one that we have developed in an engaging process, hopefully with all of you here, with all of the member states of the region. So why, you might ask, do we need such a framework right now? Well, first of all, we seem to often have our own sort of definition, understanding of what behavioral and cultural insights are and how they can be applied for value in our region. So I say let's work together to agree on shared approaches and shared interventions with evidence for impact. Second, we want to use this year to get a better overview of this work currently ongoing in countries. And once we have that understanding together, let's work together to set joint and ambitious targets for more that we can put in this framework. And then last, countries can use this framework to demonstrate their commitment to applying behavioral cultural insights in their efforts to strengthen health services, health promotion in a people-centered manner. So, starting today and over the next year, we will be reaching out to member states and to all interested stakeholders and partners really in the region that want to be a part of this process. We have already asked member states to nominate official behavioral and cultural insights focal points that can engage, and many of you have already nominated focal points. We've also launched a survey to get your feedback on the work currently ongoing in this area, and Some of you have completed that survey already. We'll be ensuring a range of consultation opportunities so that anyone interested can really be engaged and take part in the process, and we will ensure ample time for this process. So stay tuned. Today is really just the beginning. And with that, I want to just hand over to our regional director, Dr. Hans Kluge, who is joining us today and has been so kind to close the meeting.
Thank you very much, Katrina. And dear colleagues, guests and friends, thank you very much for attending this very important Regional Committee side event and sharing your experiences and insights. Thanks also to the organizing team and our translators for their help today. And in particularly, I would like to express appreciation to our co-hosts, to Austria, and danke schön, Christina, to Portugal, Miguel, thank you, Russian Federation, thank you to Maria and Professor Drapkina, spasiba, not least for presenting your experiences in measuring health literacy, translating the findings into action, and implementing interventions for better impact. Because ultimately that's what you want, to have an impact. And I found these very encouraging examples of applying behavioral and cultural insights in practice. Remember, this is one of the 4 flagships of the EPW, the European Programme of Work. The whole idea I had is that we needed very much this behavioral and cultural insights unit. It's a new unit. I'm very proud of it. We are the only one in WHO globally. If we want to tackle the risk factors, the obesity and the alcohol and the lack of physical activity, and then the team really showed its agility to switch quickly to help with the COVID-19 response, including not at least many behavioral services in many countries to find out more why there is vaccine hesitancy. So I'm very proud of the work that the team has been doing. As the little introductory video said, we hope you found this event interesting and engaging. And as Katrina just mentioned, there are several opportunities for further engagement, and we need very much this engagement. First, in order to address critical health challenges such as cancer, antimicrobial resistance, diabetes, epidemics, and other communicable and non-communicable diseases, we need the political commitment and investment in understanding the barriers people face, and then applying evidence-informed solutions. For example, on the COVID-19 skepticism, we see still that in many countries, policies are being made based on assumptions, on perceptions, but not on factual research and data. Second, we need both financial resources and in-country capacities. So let's strengthen the capacity together. And there will be a fantastic school on that one that we are working on with the Russian Federation to further strengthen capacity in the region. Third, by working together, we can achieve much more, really much more. I myself also, this was again a tremendous learning opportunity. So we need to continue this cooperation. Finally, all of us, we have to walk the talk because people are looking to us. We are the health leaders in the region. So people look, how do we walk? How do we talk? How do we behave? I myself, I get many remarks when I'm biking. No, after more than 10 years, I became half a Dane in Copenhagen here. So we're all biking. It's very important. 30 minutes exercise each day. And we have to show the example, really. Also, we made a lot of progress, as you know, in the Regional Committee with healthy breaks and having fruit at the breaks. I myself, I also don't believe in extremes. So only fruit or only sweet, there has to be a little bit of balance in life because it's very important that our efforts are sustainable. So we need a good balance. And I want to thank also finally Austria, Belgium and Germany for making our work possible and the team. I'm very proud of the team of Nino, Dr. Nino Berzulli, of Siddhartha, who is supporting, Katrine, Fiche, Anastasia, because ultimately I'm always very impressed with how few people that we have to do an enormous work, but it's the work ultimately that you are doing, and we are compiling and exchanging. Thank you so much, my dear friends, for another very, very exciting session, and now it's time to do also some exercise and move from the chair. Thank you so much, and see you later.